Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center with our Monday afternoon Instagram chat. Today's topic is gestational surrogacy. When do I need to go that route? And to start off, we just need to talk a little about what is surrogacy, and particularly gestational surrogacy. How is that different from true surrogacy, and who is a candidate for this? When do you need to consider it, and how is it all done? So everything you never wanted to know about surrogacy in 20 minutes or so. But basically, as we've talked in the past, you need a few things to get pregnancy to occur normally. You need good sperm, or sperm that at least we can use to fertilize eggs. We need eggs that are decent quality to produce embryos, and we need a uterus for the embryos to grow in. And as many of you know, that the sperm can come from the male partner, it can come from a sperm donor, the eggs can come from the patient, it can come from an egg donor, and the uterus also can be the patient or what's called a gestational carrier. So the gestational carrier is somebody who's carrying the pregnancy for somebody else. And the difference between true surrogacy and what we refer to as gestational surrogacy is that a gestational carrier does not have any biologic relationship to the baby that she's carrying. And so if we had a couple and we took the sperm of the partner and inseminated a third party to get pregnant, and then for that person to carry the pregnancy, deliver it, and then become the couple's baby, that would be true surrogacy, because the woman carrying the pregnancy would be the origin of the egg. And that we try to avoid as best possible because of the issues involved with whose baby is it, and the woman would have to give the baby up for adoption in that sense, because the origin of the egg was the woman who carried the pregnancy. So to avoid that conflict, we want to make sure that the woman who is carrying the pregnancy, the gestational host, has no biologic identity or no biological contribution to the embryo that's being placed into her. So that in essence, when you use a gestational carrier, you're renting a womb, so to speak, and you're just hiring this person to carry the pregnancy, but the embryos that are placed in that uterus, whether they derive from your own egg or a donor egg and your partner's sperm or a donor sperm, but legally the embryo that's being placed in the gestational carrier belongs to you as the intended parents, rather than the gestational carrier having any biologic identity to it. So the first question beyond that is, well, why would you even need to consider this? Who should consider this, and under what circumstances? And you can break these down into medical reasons and social reasons. Medical reasons, if you're producing eggs and sperm and making embryos, but there's something wrong with the uterus, or the uterus has been removed. In the extreme case, you have somebody that might have been treated for cervical cancer or endometrial cancer where the uterus is absent, but there was no reason to have to remove the ovaries, so we can get eggs from the ovary, fertilize it with the sperm, but because the uterus has been surgically removed, we need to use somebody else's uterus to carry the pregnancy. You also have patients that have had extensive surgeries or have significant adenomyosis with recurrent pregnancy failures. You can have patients that have severe scar tissue on the inside of the uterus due to either infection or recurrent surgery. Patients that have fibroids that have grossly distorting the cavity that are not easily removed to be able to correct that and then proceed. And you've had some patients that have undergone endometrial ablation procedures where they purposely destroyed the lining of the uterus to prevent abnormal bleeding. And other patients have been treated with radiation treatment for cancer. So all of these patients have a uterus that's either absent or that isn't going to work properly. And if you're going to put embryos into a uterus, because of the expense of IVF and the time commitment to getting this all done, you want it to have the best chance of working. Social reasons, women of increased age, and the big question always is how old is too old? In general, we use 50 as a cutoff for gestational carrier. In rare circumstances, we might stretch that a year or two in a very healthy woman. There are a lot of unknown risks as women get older. There are concerns of hypertension, diabetes, strokes, cardiovascular disease, effects of just being older and carrying a pregnancy with the stress that pregnancy puts on a woman. And then there's, a group of women that just don't want to carry a pregnancy. You've got either women, some that have had severe, nausea associated with pregnancies in the past. They get really sick during pregnancy. They have a medical condition that might get worse if they get pregnant, and so it's recommended not. But social reasons, some people don't want to be pregnant. They want a baby, they want a biologic child, but they don't want to go through the process of being pregnant. Whether you're a TV person or a model or somebody where you just can't spend the time out of your career to do that, or you just psychologically prefer not to carry a pregnancy, that's also a doable option. And then we have a treatment of a male couple, basically, where obviously the big advantage, if you have two women that are trying to get pregnant together, we've got to use a donor sperm, but that's pretty easy because we've got two sets of eggs and two sets of uteruses to choose from. But if we've got the reverse, if we've got a male couple that want to have a child, then the only way they can do that other than adoption is to use their sperm with a donor egg and have a gestational carrier carry the pregnancy. So those are all the reasons that one might entertain using a gestational carrier, and it's going to be different for each couple and each intended parent. The intended parent we refer to as the couple or the person that's basically contracting with the gestational carrier to carry the pregnancy. How is this done? Again, we're using IVF technology here. In vitro fertilization involves a couple of basic steps. One is producing eggs and getting the eggs. That's done with the woman taking fertility drugs, in this case most commonly the intended parent, and in some cases the use of donor eggs, where you're on fertility drugs for between 10 and 12 days. During that time we do some ultrasounds and blood tests to see how the ovaries are responding, and then we can take the eggs by aspiration transvaginally under ultrasound guidance, which is done under sedation, and collect a bunch of eggs. The sperm, obviously, the partner produces and gives us a sperm sample. And under the microscope, we can inject each egg with a viable sperm and then let the embryos develop. Many patients choose to do what's called pre-implantation genetic testing, which is on the 5th and 6th day of development. When the embryo looks like a little soccer ball, you can, under the microscope, biopsy some of the cells on the outside of the embryo and send those for genetic testing, and that'll help us determine whether that embryo has genetic competence. Does it have the correct number of chromosomes, or is it an embryo that's just most likely either going to stop developing, miscarry, or in a worst case scenario result in an abnormal offspring. So pre-implantation genetic testing with 98% accuracy is going to tell us that the embryo is euploid or normal and has a good chance of implanting. So once we have embryos, they're usually frozen and they're available, and we have to prepare the gestational carrier's uterus to be able to carry the pregnancy. And this is done in a similar manner as any frozen embryo transfer cycle. What's very important when we're using the gestational carrier is that we make sure that we turn off the gestational carrier's own cycle. We don't want the gestational carrier ovulating in the cycle that we're putting an embryo in, because we need to prove beyond any reasonable doubt that the embryo that the gestational carrier is pregnant with is the embryo that legally belongs to the intended parents. So by using Lupron to shut down the gestational carrier's menstrual cycle before we start any medications at all, we've shut down their system so they do not ovulate, and therefore there is no doubt at all as to the origin of the embryo that's going to implant and develop. And that's important because as physicians, one of the things that we'll be asked to do by the attorneys that are involved in this process is to sign an affidavit stating exactly that the only biologic origin of the baby that's developing is from the embryo that we transferred, and that it cannot be a biologic origin for the gestational carrier or host mother that's carrying it. So we turn off the gestational carrier cycle with a medication called Lupron, and then once the cycle is turned off, we use hormone replacement, a sequence of estrogen in the first half of the cycle, and then with the addition of progesterone to the estrogen in the second half, we prepare the lining of the uterus so that an embryo has a good chance of sticking. If we put a normal euploid, genetically competent embryo into a normal uterus, then we're going to have a very good chance, a 50-60% chance, that even with a single embryo transfer, this embryo is going to stick, and miscarriage rates will be as low as 10%. So that's the basic, how it's done, basically. Selection of a carrier is very important. This person is going to be carrying your child, and there are two aspects to selecting the gestational carrier. From the medical side, from our side, from the medical side of our side, we want to make sure that the gestational carrier has a normal uterus, has been tested for infectious diseases, and is a reliable person. And we get some of that from just one, looking through the medical history. Did they have previous pregnancies, which is recommended to have at least one previously, so that it's not a first-time pregnancy and dealing with childbirth and all the emotional aspect of it. Second, we need to know that they're medically healthy and that they're not at risk for any obstetrical complications or medical complications of being pregnant. It doesn't matter if they've had a cesarean section or not a cesarean section. We need to know that they have no active infectious diseases, AIDS, hepatitis, syphilis, gonorrhea, chlamydia, and most importantly, we need to know that their uterus is normal. And we assess that both by clinical exam, transvaginal ultrasound, and office hysteroscopy, where we can take a little telescope and look at the inside of the uterine cavity to make sure that it's a normal shape, size, no infection, and that an embryo has a good chance of sticking. They do get tested for drug screening, they get tested for infectious disease screening, and they get sent for psychological screening. And they have to pass all of those in order for us to use the person. The important part is the intended parents is for you to have a relationship with this person, because they're going to carry a pregnancy and they're going to give birth to your child, and this is a process that's going to go on for 9 months. So it's recommended that you meet the person, you're comfortable with them. You can choose whether you want to be involved with going to their doctor visits or not, or just talking to them or FaceTiming, whatever works basically. But you as the intended parent need to be comfortable that you trust this person, because the reality is that while they're pregnant, you can't force the gestational carrier to do anything. They're the pregnant person. They're the one that's controlling that pregnancy, even though it's your baby. And they get to decide what they want to do with that pregnancy and what they're eating and what they're doing socially and all this other stuff. So it's real important that you have a conversation with them, that you're on the same page, what happens if the baby is not normal? What happens if you need a cesarean section? What happens if there's a multiple pregnancy? Would you reduce down or not reduce down? The answers to the question aren't as important. What's important is that both as the intended parent and the gestational carrier, that you look at this the same way. So you need to have a conversation and make sure that you're all in agreement, because if you decide you want to terminate a pregnancy for whatever reason, the gestational carrier doesn't, you can't force it to. Now, at the same time, once this baby is born, once it comes out of the birth canal or has a delivery by cesarean section, again, the lawyers are important in this. They will have us sign a paper, and what they will set up is that they will have it set so that even though the gestational carrier gets to control her pregnancy because she's the pregnant patient, as soon as that baby is born, you're the custodian of that baby. This baby is yours. And so you have the legal decision making over everything that happens to that baby. If that baby comes out of the birth canal and has a problem and a decision has to be made on that baby's health in the delivery room or right afterwards, you're the one that's making it, not the gestational carrier. And so the legal involvement is very important, because we have these different things that have to be put in place. We have to be put in place an affidavit of who's the biologic origin of the pregnancy, whose baby is it. You have to put in place a thing for delivery, so that once the baby's born, who's the custodian decision maker of the health of that baby. You need to have a contract with the intended parent, how much you're paying her, how you're paying her, when do you pay her, you're paying her for, obviously if it's unsuccessful, it's less than it's successful. If it miscarries, it's less than if it's full term. If it's a C-section, is it more, and so forth. And the stipends that are involved in all that have to be worked out. And the attorneys that deal in this area of medicine do this a lot, and they're very familiar with the ranges of what's acceptable, and they can guide you on all of this. And we have lists in our office of both a list of reproductive attorneys who deals specifically in this topic, as well as a list of agencies that search for gestational carriers. A gestational carrier can be somebody you bring to us. This can be a friend, relative, sister, somebody you met, somebody you advertised for. It can be somebody that you recruit through an agency. Our office itself does not do any active recruiting for gestational carriers, but we do all the medical stuff, all the surveillance, all the medical side of getting her pregnant with your embryos. So it involves certainly having a legal input of a reproductive attorney. It involves at least one visit with a psychologist for you and your partner to make sure that you're comfortable using a gestational carrier, and they're a great resource for questions of what patients have been through this for many years and what their reactions are and so forth. And then obviously our role to make sure that the gestational carrier is appropriate from a medical standpoint, seems reasonable and appropriate from a social standpoint, and most importantly, that you're happy and feel comfortable with that person to carry your pregnancy, because you're going to have that 9-month relationship with that person. Now, what's done on the gestational carrier and what's done on the intended parents, on the embryos? The gestational carrier, we've already alluded to the multiple things that we have to do: infectious disease, psychologic, medical screening, review of records, and so forth. Because we're putting embryos into a third party, there are very strict FDA guidelines on what has to be screened for use of those embryos. And ideally, if the decision is, if we know we're creating embryos for the use in a gestational carrier, then besides the usual stuff that we do, such as AIDS, hepatitis, and syphilis screening on both members of the couple, we have to do some additional tests. We have to test for Zika. We'll test for COVID-19. We'll test for cytomegalovirus. We'll test for West Nile virus. There's a laundry list of things that the FDA specifically wants addressed. And so if you're planning to put embryos, or possibly putting embryos into a gestational carrier, it's very important that all of these things are done properly so that we have all the documentation. The FDA does come into our office at least every other year, and they review all this stuff. And there are very hefty fines and they can close your program down if you don't follow their guidelines. So these are regulations that we're very serious about, and these are hoops that we have to jump through. We have no control over them. We just have to get this information and document it. Now, there are some situations where it's impossible to do that. In other words, if we're going to put embryos into a gestational carrier, when we get sperm on the man, as well as when we get eggs on the woman, we have to do infectious disease testing and an exam to make sure that there's no evidence of any risk of infectious diseases that we can transmit. And in the guy, it's within 7 days of getting the sperm. And with the woman, we usually do it within 7 days as well, but it could be a few, I think it's 30 days maximum. But the key is that we have to do these exams before the sperm is used to fertilize the eggs. But what happens in a couple where we've created embryos and the embryos are in the freezer, and for some reason, between the time period where those embryos were created and the time to use them, let's say you created some embryos, you found out you had cervical cancer, uterus is now removed. Now I've got these embryos in the freezer. I want to use them to get pregnant, but I don't have a uterus, but I didn't do this testing before. So in patients that have not had the infectious disease testing of embryos that are already created, in that circumstance where the intent was not to put the embryo into a gestational carrier, but the circumstances are that that's the only way we can use these embryos, we can use them as long as the gestational carrier is aware of the increased risk of infection. So that means sitting down with the gestational carrier and go, hey, this couple didn't intend to use these embryos in this way, but have no choice. And even though they're infectious disease negative when the embryos were created, they've had no evidence of infectious diseases since. The full panel wasn't done at the time the embryos were created because there was no reason to. And as long as you're okay with that added risk that those tests weren't done at the time with this batch of embryos, we can proceed. So we can get exceptions to the rule as long as we document it and there's a real reason to do it. But if we're thinking at all of using a gestational carrier, then we need to do the testing ahead of time. The way the embryos are transferred is no different than a frozen embryo transfer cycle. We recommend transferring one embryo if it's a genetically tested euploid embryo. If they've not been biopsied embryos, then depending on the age at which the embryos were created, were the embryos when the mom was 34 or was she 42, that might influence the number of embryos that we would agree to transfer on that person. But if they're genetically tested embryos, our best recommendation for the safest pregnancy, for the best reproductive outcome, is one embryo at a time. The gestational carrier is on hormone replacement with estrogen and progesterone because her ovaries have been turned off. And so 9 days after the transfer, we do a pregnancy test. We also monitor their estrogen and progesterone levels, and if positive, we'll monitor them every week or two until we wean them off of the hormones. What happens naturally is that in a normal pregnancy, the ovary makes the hormone that supports the pregnancy, and it's being stimulated by the pregnancy hormone called HCG that the placenta makes. And with a frozen embryo transfer cycle, when the ovary's been turned off, the HCG is still being produced by the placenta, but the ovary can't see it because the ovary's been turned off. So we have to provide the hormone initially, estrogen and progesterone, and then as time goes on, between the 8th and the 12th week of pregnancy, we see more and more hormone production by the placenta. And so the baby's making its own juice, basically. It's making its own hormone to support itself. And in a natural pregnancy, after the first trimester, you don't even need your ovaries. And that's the point where you don't need us to give you any hormones. So we wean between the 8th and 12th week, we'll wean the gestational carrier off for estrogen and progesterone. And basically at that point, it's just like any other pregnancy. You can deliver vaginally if the obstetrical indications are fine. If from an obstetrical standpoint, there's a need for a C-section and they need to have a C-section. But it's not related to how they're getting pregnant or the fact that they're a gestational carrier. And that's pretty much the whole thing in a nutshell. It works really well. If you've had recurrent embryo failures, in a young healthy person that's doing IVF and has had recurrent, hang on here, with a couple that's had recurrent embryo failures, we've had some patients that, for whatever reason, the lining of the uterus never develops normally and it doesn't work. And so we have a small group of patients that have unexplained implantation failure on a recurrent basis. And that's another group that works really well with a gestational carrier. And we've been very successful in those rare cases when we've gone that route. Question, who decides if a couple qualifies for a gestational carrier? Can an REI deny the couple the use of gestational carrier? As with any part of medicine, you've got the ethics of what we're doing, and different people have different feelings over different things. We believe in educating patients and providing them with options in our program, as well as the best possible care. We don't second guess. If a couple wants to use a gestational carrier, we may have a discussion with them as to why we don't think that that's needed at this point. But if they want to use a carrier because that's just the way they want to get pregnant, we're okay with that. It's not necessary medically, but if socially, psychologically, this is something that you want to use, it's fine. Now, we feel that way, and that's the way our center is. I can imagine that there are probably some centers that don't think that that's appropriate. If you have a normal uterus, you should do that, and you shouldn't have the ability to do this for social reasons. But part of that conversation should be, if that doctor did not feel that they could offer the service to you, then they should refer you or encourage you to seek being taken care of by a center that would. So I have no problem with any physician not providing a service that's sort of elective that they feel uncomfortable with. And from a practical side, as a patient, you don't want a doctor doing anything that they're uncomfortable with. But, we don't have a problem with the concept of gestational surrogacy. We don't have the concept of treating two gay men with a gestational surrogate. We don't have a problem with a patient who wants to use a gestational carrier because they just they don't want to get pregnant for whatever reason. But obviously, from the medical side, the reasons we discussed earlier were the best reasons to need one. Gestational carriers often are out of state and can be out of state. It's obviously simpler if they're in Miami and you're in Miami because it's easier to go to visits with them and stuff, but some of them live elsewhere, and there's no problem with that. They have their doctor visits elsewhere. In this crazy times of a new normal with COVID and stuff, doctors' offices are not crazy about having 4 people march into every office visit anyway. So this is where the magic of your iPhone or Android phone, whichever it might be, comes in a very handy way, in that you can be present at that doctor visit without having to be there. And as a courtesy, if you're going to use this technology, just please ask the doctor before you turn on the iPhone that, is it okay if, I'm a gestational carrier, the intended parents want to be part of this visit. I know your office is not letting anybody but me in today. Would you mind if I get them on the phone so that they can be part of it? But monitoring long distance is not a problem. Blood tests can be done pretty much anywhere. Once they're pregnant, we're just monitoring blood and making sure that the medications we're giving you are being absorbed properly, and we're looking for evidence that your placenta is producing its own hormones so we can cut back what we're giving you and wean you off of this stuff by the end of the first trimester. So distance isn't an issue. Technology helps a lot. And the key here is just, if things aren't working from pregnancy because the uterus isn't normal, or because you just don't want to carry a pregnancy, gestational carrier is the way to go. As far as how many births or C-sections, we try not to use gestational carriers that have had more than 4 births. I think 5 is the max. C-sections, preferably no more than 3. There's always exceptions to the rule. If it goes beyond that, then we request that the gestational carrier see a maternal fetal medicine specialist and get clearance, basically. But if they're going to have a more complicated delivery, is it really that smart to choose a gestational carrier that's going to have potentially more complications? You want to pick the one that's not going to have the complications, basically, either for your baby or for the carrier themselves. So, if it can't, sometimes there are reasons because it's a family member or this or that, or I really have my heart set on this person. But if red flags come up, the best thing is find a different gestational carrier. As far as do we provide a list of carriers, we provide a list of agencies that search for carriers for people. We don't provide carriers like we do with egg donors. It's not part of our normal activity. And we're happy to work with any gestational carrier that you find, whether it's somebody you find locally or you recruit yourself or you go through an agency. Whether you recruit it individually or you recruit it through an agency, you still need to have psychological involvement and you still need to have legal involvement. A lot of the agencies have their own recommended legal counsel, and they've done this many, many times, so sometimes you might find some savings in that regard. And the key when you're looking for a carrier is use the resources of multiple agencies. Usually you're not paying much until you find a gestational carrier you like. One agency may have somebody you really like and another agency somebody you're not. It's real important that we review who you select. We want to make sure that not only are you getting a gestational carrier, but you're getting a gestational carrier that we feel is going to give you the best possible reproductive outcome. And sometimes we don't find out that there are issues until we do an ultrasound or a hysteroscopy, and then we go, this might not be the best person. You want to try and find somebody that doesn't have any red flags, that at least going into this, you have the best opportunity to get pregnant. If someone's got a history of recurrent miscarriage, why would you want to put your embryos, which are very valuable, into that person? Anybody can miscarry, but if someone's had 3 or 4 miscarriages, it tells you maybe there's something wrong. Pick a different person. So we'll help you along the way. We'll guide you. We have 3 nurses that really do nothing other than third-party reproduction. It's important for us to review the records of gestational carriers. The agencies we work with, once you instruct them to and have signed HIPAA forms, and the gestational carrier has signed HIPAA forms for us to review their records, we'll send them to us, we'll review them, and we do that before we bring the person down. particularly if they're out of state. We don't want them coming in, and we don't want you having a bunch of expenses until we know things look pretty good. So that's the whole thing in a nutshell. If this is something you want to explore further, please feel free to let us know. Come on in. We'll set up a Zoom visit. You can come in person, but we're available to you or any of your friends that this may be a good means of conceiving. And I wish everybody well, stay safe, and have a great Monday afternoon.